Okay, this is the procedure for SOT Category 1. The first thing I'm going to do is check leg lengths on my patient. I'm going to look at the medial malleoli for superiority. The most superior one is the short leg, and I'm going to keep that in mind while I move on to trap fiber analysis. And so there are areas on the trap that are responsive to different areas in the spine for subluxation. Zone 1 is going to be medial to the AC joint. I'm going to start there. I'm going to end 3/4 of an inch lateral to the spinous process of T1, and that's zone 7. All the other zones are evenly spaced out throughout the trap fibers. And I'm going to ask the patient for tenderness and note which one as they correlate to different areas in the spine. So, is this tender?
No.
Is this tender?
Nope.
Is that tender?
A little.
Okay. Is that tender?
No.
Is this tender?
Yes.
Is that tender?
No.
Okay, so his most tender points were 3 and 5, and I'm going to ask which one was most tender. So is it 3 or 5?
5.
Okay, and then I'll do the same thing on the other side. So, is this tender?
No.
Is this tender?
No.
Is this tender?
A little.
Is it more tender than this 5 over here?
No.
Okay. Is that tender?
No.
Is that tender?
No.
And tenderness there?
No.
And here.
Mm-hmm.
Okay, so his most severe zone on his traps was 5 on the right, and that's going to correspond to C5, T7, and L3. So I'm going to check each of those spinuses for tenderness as well. So is this one tender?
Yes.
So C5 was tender. I'm going to come to T7, and is that tender?
No.
And L3, is that tender?
No.
So his most tender spinous was C5. To adjust, I'm going to take a knife edge contact and reinforce with the other hand. I'm going to go inferior to the spinous, and I'm going to do a quick thrust, I to S, and just like that. And then that should clear up that trigger point and that segment. The next thing I'll do is the heel tension. It should be on the short leg. It usually is. I can check by looking at the Achilles tendon for thickness and more development, and I can squeeze them to see if one is tender or not. And which one is more tender?
The left.
Okay, and so that's normal. It should be that way. And so to fix this, I'm going to take the patient into flexion 90 degrees in their knee, and I'm going to alternate doing dorsiflexion and plantar flexion to correct that a number of times. The next thing I'm going to do is check for atlas dural subluxation, and I'm going to monitor the feet and as they change while the patient turns their head right and left, because that's the relationship of the atlas and the dura. So if you'll turn your head to the right leg should shorten, and turn your head to the left leg should shorten. Now the left leg shortened when he turned his head to the left, but it didn't shorten when he turned his head to the right. So that means his atlas is subluxated to the right. So to correct that, I'm going to, I would do distraction on his long leg first, and I would do that for 10 seconds, 3 times with 10 seconds in between each time. Then I'll traction the other leg, the heel tension side. Oh, the short leg. Oh wait, wrong leg first. First I would do the right leg for 10 seconds, 3 times, and then I would do the left because that's his short leg. And as I'm doing that, I'm going to have him turn his head to the right and left, alternating, using full range of motion. And I do this for a while. Then the third step is to do the tension on the heel tension on both feet, and then I traction again for 3 times for 10 seconds with 10 seconds in between each time. Now I'm going to check for his crest, major crest and dollar signs. The crest sign is going to be the erector spinae and the quadratus lumborum muscle groups. I'm going to take my thumbs medially on each side. I'm going to look for the stronger side, the more healthy side. That's going to be the major side. I'm also going to take 4 fingers and do the Davis compression. That was the stretch. This is the compression. And it just helps me confirm, again, which side is the major side. And his left is more major. Then I'm going to check for the major dollar sign. I'm checking for tone of the muscle and the gluteals, and for which one has a little more rebound. And so that would be his right side. So he has a right major dollar sign, a left major crest sign. Then I'm going to compare the two and see which one is more severe between them. So I'm going to say his crest sign is a little more. Then that determines how I'm going to block him. So let me get my blocks. He's a left short leg. He's got a left crest sign, major crest sign. I'm going to block by putting this underneath, the one on his short leg underneath his greater trochanter, and it's going to be going up superiorly like this. So it's passive blocking, so I'm going to move the patient with the help with his leg and leverage. I'm going to place the block underneath his trochanter, going this way, and then I'm going to do the same with the other side underneath the ASIS, and it will be pointing inferiorly. Once he's there, I'm going to check to make sure his gluteals are even, make sure that he's balanced, and the goal is balance for these crest and dollar signs and for his torsion in the spine and CSF flow. I can leave him there for up to 10 minutes. Before I do, I'm going to make sure I'm checking his leg lengths and make sure nothing's getting worse to see if I need to reevaluate the patient or readjust the blocks. So while he's blocked, I'm going to do the adjustment for his major crest sign. So what I would do is and there's 3 rules. You never adjust over a block. You never remove a block to make an adjustment. And what's the last one? And you only adjust the side, you only adjust one sign or the other. So I'm going to take my knife edge contact, reinforced with my other hand, on the superior portion of his iliac crest. I'm going to do a roll adjustment onto his lower lumbar muscle groups. And then I'm going to come to this side. I'm going to do a toggle adjustment, P to A, on the ischial tuberosity. And that's just a quick thrust like that. And that should clear up that crest sign. The next thing would be checking for his sacral base subluxation. I'm going to take my hand, I'm going to place my thumb on the spinous of L5 with my fingers facing towards the patient's head. I'm going to do a cough test. I'm going to ask him to cough while I'm watching my hand and cough again. So when he coughed, it made my hand go up towards the ceiling, which indicates that he is a sacral base positive. And that means that his sacral base is more anterior, and I need to contact the apex of his sacrum. As he inhales, I'm going to push with the natural flexion and extension of the sacrum during respiration. I'm going to push on his apex as he breathes in and release as he breathes out. I'm going to do this 3 times, 3 or 4 times. And that should take care of that. The next thing I'm going to do is the vasomotor. So, checking the tender, I'm going to go all the way up each spinous process in the lumbars and the thoracics, and I'm going to look for the most tender one. And so tell me just if one is tender, and we're going to make a note of that. I'm pressing superiorly on each spinous.
There.
So this is a tender one. This is about T12, T11, and I'm going to keep going. We're going to find the most tender one in his spine, and then that's going to correlate to a certain cervical vertebrae.
There.
Here. So that's about T5. So,
just those 2.
okay. So, and then between the 2, which one was more tender?
The lower one.
This one?
Mm-hmm.
Okay, so T12 correlates to C1. So what I'm going to do is I'm going to take my thumb and I'm going to place my hands on the sides of C1 where it would be and just place them there. As I press up on the spinous for 5 seconds and lay off the spinous for 5 seconds. And I'm going to go through that a couple times until I start to feel moisture or tackiness along the sides of his neck where that vertebrae is, the correlated one. And that should fix him. The end.